So welcome all again to this session, and in this particular week we are going to deal with the topics of abdomen and pelvis from 11th to 15th of March. Fair. So I'm Dr. Ankit. Welcome to our channel Human Anatomy by Dr. Ankit, and let's start the first MCQ over here. So here's the first MCQ. The question asks, a man is admitted to the hospital with an indirect inguinal hernia, right? Indirect. During an open herniaplasty, the spermatic cord and the internal abdominal oblique muscles are identified. Which component of the spermatic cord is derived from the internal abdominal or internal oblique muscle? So we know that in the abdominal wall we have few muscle layers. If you go from outside, we have the external oblique, then you have internal oblique, then we have trans abdominis. In the center, or you can say around the midline, we have a vertical muscle that is also rectus abdominis. Okay. Now there are few derivatives which we should be knowing. What are those? External oblique over here gives rise to external spermatic fascia. The internal oblique over here gives rise to the cremasteric fascia, or you can say the cremasteric muscle as well. The trans abdominis does not normally form much in the anatomy of the inguinal canal, but deep to trans abdominis, we have a fascia known as the fascia transversalis. I am sure you must have heard about it. Now this fascia transversalis over here, it gives rise to internal spermatic fascia. Right. So these are the coverings of the spermatic cord. So here they are asking about the internal abdominal oblique or internal oblique muscle that mainly gives rise to the cremasteric fascia or the cremasteric muscle, and I am sure one of them should be the options over here. Here it is. That is our cremasteric muscle as the answer. External spermatic fascia already we have seen, external oblique, internal spermatic fascia from fascia transversalis, and tunica vaginalis is actually a prolongation of the peritoneum, that is also known as processus vaginalis. So just write over here the peritoneum, and it is where the fluid gets collected during hydrocele. Here is a simple image over here. Let us highlight few layers. So this was the external oblique, that is internal oblique, this is trans abdominis, and this from deep ring to the superficial ring over here we have the inguinal canal. So this whole over here, that is the inguinal canal. Right. So this internal oblique over here, as we are discussing, gives rise to the cremasteric muscle in the cremasteric fascia. Remember the cremasteric reflex also. For the cremasteric reflex, do remember that in cremasteric reflex, the root values that are checked are L1, L2, and the nerves over here are basically which are being checked are the genitofemoral nerve, coming from the lumbar plexus. Let's see the next one over here. Okay. After moving a heavy equipment at a construction site, a 42-year-old man goes to his family physician with a bulge in his left groin that does not descend into the scrotum. So there is bulge. So there is a bulge in the groin that is not descending into the scrotum. It is only in the groin. And there is history of moving heavy equipment. The patient reports the bulge becomes more prominent when he is standing or cuffing. In standing up and cuffing, the bulge is more prominent because of increased intra-abdominal pressure. On examination, the doctor places his finger in the location of the bulge and notes that his finger feels like it can pass into the abdominal cavity. So there is opening there. Given his presentation and history, what is the most likely diagnosis? So it's imagine you are sitting in an OPD and a case like this comes in a surgery OPD. Middle-aged man, history of heavy work done, and there's a bulge in the groin which is not going into the scrotum, and it increases on standing and cuffing. Middle-aged man, it is most probably a direct inguinal hernia. It is more probably a option A, direct inguinal hernia, that is coming through the Hasselbeck's triangle. Now let us see that too. In the previous image only we can see. Here if you look in the previous image, then here you have the rectus abdominis muscle. So this is the rectus abdominis muscle. Just medial to deep ring we have the inferior epigastric vessel. And if we take this vessel over here and the lateral border of rectus abdominis, this whole area becomes what? It becomes the Hasselbeck's triangle. And hernia, if it comes out from here through this area, that is known as direct inguinal hernia. Now it is not entering directly into the inguinal canal, so therefore this hernia does not enter into the scrotum normally. Normally it does not go into the scrotum. While on the other hand, if the hernia is entering through the deep ring right over here, then if it passes through the canal, then obviously it can enter into the scrotum. So normally the direct inguinal hernia occurs in a middle age and due to recent activity of heavy work and weak abdominal muscles. On the other hand, the indirect hernia which enters through the deep ring, normally occurs in childhood, or it could be infantile in infants, okay, in small age group, younger age group. Some of the differences here, the answer is direct inguinal hernia. If you look at other options in that, as I told you, the whole history will be different. It is normally seen in young or childhood. Femoral hernia is actually present below and lateral to the pubic tubercle. It is more common in females than males because of wider pelvis, and its location is below the pubic tubercle, right? Not in the exactly in the groin area, in the, you can say, upper medial thigh area. This is where we will have the femoral hernia. Now this hernia is through the femoral canal. Femoral canal you will see in the lower limb, as we have done the lower limb also. It is present more medially, right? If you look at the femoral triangle area, more medially we have the femoral canal. Lymphadenitis of superficial nodes. Now this lymphadenitis is actually you can say inflammation of the lymph nodes. It can be present as a bulge, but it won't be increasing on standing or coughing. Won't have a typical history like this. It could be from inflammation anywhere in the abdominal wall below the umbilicus. So anywhere inflammation in the abdominal wall below the umbilicus could lead to superficial linguine lymphadenopathy, or in the lower limb as well. Right. So remember that. So this is how we can rule out and come to the option as A. Fair enough. Let's see the next one. A 48-year-old lady has been scheduled for cholecystectomy, that is removal of the gallbladder. During the operation, the scissors accidentally entered the tissues immediately posterior to the epiploic foramen. So there was a mistake, right? Immediately behind the epiploic foramen or the foramen of Winslow, the scissors actually entered the tissue. The surgical field was filled immediately by profuse bleeding, and that's a danger sign. There is a profuse bleeding, right? Which vessel was most likely so? So basically they are asking that, do you know the anatomy of the epiploic foramen or foramen of Winslow? And if you know, then do you know what lies behind this foramen? Basically, which vessel lies behind this epiploic foramen? That's what they are asking. So if you look over here about the epiploic foramen, this is a cadaveric image. Let me tell you a few things over here in this particular image. This, what you seeing is the liver over here. This is the STO stomach. That is the greater omentum. And this, if I put an arrow, that is the lesser omentum. And if you look at behind the right margin of lesser omentum, this opening over here, this is actually what is our the epiploic foramen, right? Epiploic foramen. We can say that it is behind the right margin of lesser omentum. Lesser omentum itself is from the hepatogastric and hepatoduodenal ligaments. Now, which vessel do you think is present over here behind the epiploic foramen? The answer for that is, do you know the boundaries of epiploic foramen? If you know, then answer becomes very easy. So let us see the boundaries of epiploic foramen. So epiploic foramen will have anterior boundary, will have posterior boundary, will have superior boundary, and will have inferior boundary. Let us see. What lies anteriorly? As you can see, the right margin of lesser omentum. So anteriorly we have the lesser omentum. What is inside lesser omentum? We have the portal tride structures. What is that portal tride? Portal vein, hepatic artery, and the bile duct. What is lying behind? Behind actually, that is the question is IVC, inferior vena cava, and that was actually the answer. What lies above? Above you can see above is the liver. Basically, we have the caudate process of the liver. So basically above we have the liver. And what lies below? Below you have the continuation of stomach. And the continuation of stomach over here is basically your D1, the first part of duodenum. Okay, right. So the answer for there here will be IVC. If you look at another image over here, here is the epiploic foramen is shown at this site. This is more anterior, this is more posterior, and therefore behind you are seeing the IVC, anterior you are seeing the portal tride structures, right? So if we come back to the question over here, we can confidently go with the inferior vena cava, option number B. Option number B over here. Okay. So coming to this question, which of the following anatomical relationships would be seen clearly on exploratory laparoscopy without dissection? When the surgeon exposes the beginning of jejunum. So here they are asking that, okay, you are about to reach the beginning of jejunum. Now anatomically, what structures would you be seeing over there? Okay, it's an exploratory laparoscopy. So we all know that jejunum is a intraperitoneal organ, and once you open up the abdominal wall, you see a greater omentum, you lift it up, then you see the jejunum and ileum. Jejunum is upper end to the left side, ileum is lower end to the right side. Now there's a whole tube, it's a long pipe, and you reach the beginning of jejunum. What do you see then? Option A, the second portion of the duodenum is related anterior to the hilum of the right kidney. See, it is right, the statement is correct that the second portion of duodenum is in front of right kidney, but both the duodenum and the right kidney are retroperitoneal, so we won't be seeing it directly, you won't be seeing the kidney directly. So it is right, but you won't be able to see it. The superior mesenteric artery and vein passes posterior to the third part duodenum. We will subsequently see that these two structures, they don't pass posterior, but they pass anterior to the third part of duodenum. So statement itself is wrong. The portal vein crosses anterior to the neck of pancreas. Portal vein is formed behind, posterior to the neck of pancreas. So again, we come to the answer. Answer has to be option number D. Second part of duodenum is crossed anteriorly by the attachment of transverse mesocolon. This is what you will see. Why? Because though duodenum is retroperitoneal, but here they are talking of the structure in front of the duodenum. So obviously you see the transverse colon and the mesocolon. That mesocolon passes in front of the second part duodenum. So this is what you will see. Option number D. Let me show you an image over here. Right, this is an image basically trying to show over here the four parts of duodenum: first, second, third, and fourth. These are the anterior relations. So here you can see that this is what they actually asked. In the second part of the duodenum, you can see the attachment of the transverse mesocolon over here. This is what you will see. Superior mesenteric vessels are in front of third part duodenum. Okay, remember that. Now, if we go to the posterior relations over here, again the duodenum, same thing, but posterior relations. Here the second part of duodenum is in front of right kidney, fine, but you won't be able to see it because it will be all be covered by peritoneum. That's the whole point, right? And you can see the veins over here. This is IVC and the aorta, and this is the portal vein. So they are all behind the pancreas and the duodenum, the portal vein and all, right? So considering this image, we come to the answer as option number D over here. It's a really good question. Try to understand this. Fair enough. One more question. A patient with a pancreatic insulinoma is being prepared for a laparoscopic enucleation of the tumor. After induction of GA, preparation of a sterile surgical field, and port placement, the surgeon needs to enter the space posterior to the stomach to access the pancreatic tumor. This, see, pancreas is retroperitoneal. It is lying at the stomach bed. So you need to go behind the stomach. And this cavity behind the stomach, what is that cavity known as? That cavity is known as the lesser sac or omental bursa. That cavity is known as the lesser sac or omental bursa. Right? Now, which ligament must be cut in order to access this space? That is the question over here. So here, if you look at this image, first of all, understand, this is the stomach over here. Stomach is an intraperitoneal organ and it is covered by various ligaments. On the greater curvature, you have the greater omentum. So this is the greater curvature, that is the greater omentum. On the lesser curvature, you have the lesser omentum. Right? Between the stomach and the spleen, you have the gastrosplenic ligament. Between the stomach and the diaphragm, you have the gastrophrenic ligament. Now you need to enter behind the stomach. Where is lesser sac? Actually, I am trying to show you over here. But lesser sac would be a location somewhat like this over here, behind the stomach. Behind the stomach. Lesser sac is just behind the stomach. Remember the question of omental of your epiploic foramen. So this was, if a red color I show you, this was the epiploic foramen. By inserting your finger, you actually entering into the lesser sac. So epiploic foramen is connecting the greater sac, which is lying outside the stomach, to lesser sac, which is lying behind the stomach. So remember that. So you have to reach over here. Now which ligament you need to cut? Let us see the options. Options over here are phrenoesophageal ligament. Now, phrenoesophageal ligament will help you to, if you cut this ligament, it will help you to mobilize some upper part of the stomach or lower part of esophagus. That's it. Hepatogastric ligament. Now, hepatogastric ligament over here. What is this? This is a part of the lesser omentum. If you look over here, then hepatogastric and hepatoduodenal, these are the two parts of lesser omentum. So obviously, if you want to reach behind the lesser omentum, you need to cut these ligaments. So yes, hepatogastric ligament looks like a fair option. Other option over here are phrenicocholic ligament. Now, phrenicocholic ligament is between the diaphragm. Phrenic means diaphragm, and cholic, you have the splenic fracture of the colon. Again, it helps while mobilizing the spleen, not to enter into the lesser sac directly. And finally, falciform ligament, it's connecting liver to the anteabdominal wall. So therefore, answer over here is option number B, that is our hepatogastric ligament or lesser omentum. Now, they specifically said hepatogastric. What if they would have said, just I'm giving you an extra idea, hepatoduodenal ligament? You might have thought of that too. Where is hepatoduodenal? This is hepatoduodenal. But what is the risk in cutting the hepatoduodenal ligament? Actually, hepatoduodenal is nothing but it is into the right margin of lesser omentum. And we know very dreadful structures over here surgically are present are the portal triad. You are endangering you're bringing your scalpel close to the portal right structures, close to the bile duct, close to the hepatic artery, close to the portal vein. That is danger. Hepatogastric ligament is safer, though it also has some vessels like left and the right gastric vessels are also present over here, but it has a bigger area and they can be mobilized. But hepatoduodenum will be obviously a bit more risky, right? Therefore, answer is hepatogastric ligament. Alright guys, so that's all for today's session. We'll meet again tomorrow. I hope you're enjoying it. Thank you and see you soon. If you are enjoying, don't forget to press the like button. That's all. Bye-bye.